Hello, everyone, and thanks for joining us. Welcome to the 2024 American Diabetes Association Living with Diabetes Ask the Experts series. Tonight's special program will focus on advances in type 1 diabetes screening and prevention everyone should know. I'm your host, Susan Weiner. I'm a certified diabetes care and education specialist and a registered dietitian nutritionist. Our Ask the Experts events are all about you and all about your questions and what you would like to know. So please think about what you'd like to ask related to tonight's topic, and please get your questions ready to go. We'll try to get to as many questions as possible during tonight's event. And if you'd like to ask a question, please type your question in the comment or chat box, press the submit question button, and your question will come directly to us, and I'll be able to ask it live during tonight's event. And please stay with us throughout the entire hour as we will discuss advances in screening for type 1 diabetes and provide a lot of useful and very practical information. Tonight's Ask the Expert event is supported in part by Sanofi. So thank you so much, Sanofi, for your support in making this program possible. Type 1 diabetes is often misdiagnosed and affects people of all ages, all backgrounds, all ethnicities. Early screening can provide a better understanding of type 1 diabetes and potentially improve health outcomes. Please visit diabetes.org/aboutdiabetes/type1 to learn more. And now I am honored and delighted to introduce today's guest experts, Dr. Jason Gaglia and Dr. Nicole Beriolis. Dr. Jason Gaglia, MD, is director of the Hood Center for Prevention of Childhood Diabetes and co-director of the Clinical Translational Research Center at Joslin Diabetes Center, where he is co-section head of clinical, behavioral, and outcomes research. He was previously a member of the National Institutes of Health Clinical Islet Transplant Team and was Vice President of Clinical Science of SEMA Therapeutics, a company developing a stem cell-based islet replacement for treatment of type 1 diabetes. He's been a principal investigator for numerous type 1 diabetes immune intervention clinical trials, including TrialNet, Immune Tolerance Network, and industry-sponsored studies. His current research includes developing tests to monitor the immune system with the development of type 1 diabetes. Welcome, Dr. Gaglia.
Thanks for having me today.
Of course. Dr. Beriolis is a licensed clinical psychologist and certified diabetes care and education specialist with a private practice in North Texas. She works with people living with chronic health conditions such as diabetes, MS, chronic pain, and obesity. Dr. Beriolis is the spokesperson for diabetes and mental health for the Association of Diabetes Care and Education Specialists and has interviewed for numerous articles targeted for patients and HCPs. She also frequently speaks to a variety of groups on topics related to the psychosocial aspects of chronic conditions. Dr. Beriolis earned her PhD in clinical health psychology, behavioral medicine, an MPH with a focus in health behavior, and a postdoctoral master's degree in clinical psychopharmacology. And a warm welcome, Dr. Beriolis.
Thank you so much, Susan. Thank you, Sanofi and ADA, for having me here tonight, and hello from Dallas.
Welcome. And thank you to all our participants again for joining tonight. Type 1 diabetes doesn't discriminate and can hit hard to anyone at any time. And in the United States, as many as 60% of children are in dangerous diabetic ketoacidosis, or DKA, by the time type 1 diabetes is properly diagnosed. The American Diabetes Association, along with many other organizations, are working to increase awareness of type 1 diabetes, its warning signs, and the importance of screening. Dr. Gaglia, why is it important to screen for type 1 diabetes, and what's involved in the screening process?
So classically, we used to think about type 1 diabetes as happening when blood sugars went up. But type 1 diabetes is actually an autoimmune disease that starts much earlier than that. And so by screening, we can identify people when they have the evidence of autoimmunity, but before their blood sugars go up. And as you mentioned, by identifying people early, potentially we can decrease their risk of presenting with diabetic ketoacidosis. If you look at a number of different series, about 20 to 30% of people, when they first present with diabetic ketoacidosis. But if you instead have people in a screening and monitoring program, that generally is less than 4%. So that's a very large decrease in diabetic ketoacidosis at time of presentation. And diabetic ketoacidosis is potentially life-threatening. So it's very beneficial and good to potentially identify these people early. Also, now we have treatments that are becoming available, with the first one being a drug called teplizumab, which can be used to treat some people in the early stages of diabetes. But you wouldn't know if you're eligible unless you got screened. So the second part of your question is, what's that screening process? What's it like? And so basically the screening process is to look for autoantibodies directed against the pancreas. We're not actually looking for elevated glucose when we first start the screening. We're looking for these antibodies, and that's done on a blood test. And that blood test can be done via venipuncture or phlebotomy or a finger stick, depending upon the specifics of how it's done in your area and what type of testing you want done.
And thank you so much for that explanation. You mentioned autoantibodies. Can you explain what they are and what we're looking for in those autoantibodies?
Sure. So part of your immune system is the development of antibodies. These antibodies are proteins that circulate in the blood and bind to something. And they're kind of like flags when they bind to that thing. It's like sticking a flag on it. And so, for example, if you get an influenza vaccine, you're going to make antibodies against influenza. And so if you were to see influenza, your immune system is going to put these antibodies on it, and it's kind of like flags for the rest of the immune system to recognize it. Now, autoantibodies are the proteins that are directed against self. So some protein that's normally in your body. So people who have autoimmune thyroid disease will have antibodies against their thyroid. People who develop type 1 diabetes will have antibodies against their pancreas. And so when we're screening, we're looking for these antibodies against the pancreas in the setting of type 1 diabetes.
And Dr. Barriolis, if we're going through the screening process, and through tonight's discussion, we'll learn more about the staging process, etc. So and I'm just thinking about this with so many people listening today, if there was a parent who is living with type 1 diabetes, or a parent who has a child who has type 1 diabetes and another child who is not yet diagnosed, that's very scary to go for screening. That might scare some people away, which is a barrier to this important screening process. Is there any advice that you can give on how to proceed with that fear of going and getting screened?
Anytime you talk about type 1 diabetes, there are so many emotions that come into play, right? So you mentioned people with already living with type 1, the parents, or they have a child already with type 1. So knowledge is power, and you've got to remember that. Getting that extra step, going that extra mile to do the screening gives you that power, gives you that time. Because likely with your other child who has already been diagnosed with type 1, you didn't have that. You learned immediately. You were I've had parents explain they felt like they were just thrown off a cliff when their child went into the ER due to diabetic ketoacidosis. So this is your time to further build your support network, gather the information you need to look at the options. Because like Dr. Gaglia said, our technology and our medications and our drugs are advancing at such a rapid rate that what's available to your child now likely was not available to your other child or to yourself as a parent living with type 1.
It's so very true. And it's so important to have that support and that understanding. And Dr. Gaglia, going back to the staging, can you please talk a little bit more about the staging, what that means, and about the autoantibodies in the staging process, why that's important?
Yes, so we now recognize 3 stages of type 1 diabetes. And so the classic, when someone has symptoms, when someone has high blood sugars, that's now called stage 3 type 1 diabetes. And so there's 2 stages before it in the pre-symptomatic setting. So the first stage is when somebody has autoantibodies directed against the pancreas, generally 2 or more, but normal blood sugars. And that individual, if you go out over their lifespan, more than 90% of them will develop clinical disease. But it might take time. But that's why we're now saying that they actually have type 1 diabetes when they have that irreversible autoimmunity, even though their blood sugars are normal. When they move to the second stage, the blood sugars become elevated, but they're not elevated enough to meet the diagnostic criteria for diabetes. So it's kind of the middle range. They're no longer normal, but they aren't so high that they meet the definition for diabetes. And so the way I kind of like to think about this is the stages of diabetes are kind of like mile markers. And so when you're at your destination, that's stage 3. And as you approach your destination, that's moving from stage 1 to stage 2. And again, it's the distance. It says nothing about the rate.
That's such an interesting way to think about it and response. Thank you so much to that. We have a question coming in, which is from Bailey, who asks, do you have a preference on which antibody testing is performed? Dr. Gaglia, we'll start with you.
Yeah, so this is actually a very good question because there's a lot of variability in the quality of the different autoantibody tests. And so actually we've had consortia conferences now where we kind of get together and compare the different assays. And so generally you want an assay that's been qualified in one of these so that you know how good it scores against some standardized samples. But the thing that's actually interesting with this is sometimes you'll have an assay that scores well with one sample type and not with another. And so because we actually test for multiple autoantibodies, and because you need 2 or more, because it's not just one test, it gives us a little bit more reassurance in our answers as, is this real or not? Because if you just have one autoantibody, you didn't actually hit stage 1 yet. You need 2 or more. And so you're less likely to have false positives because of that.
So he, oh, sorry.
I'm sorry,
Yeah.
one second and follow up to that, and then I'll go to you, Dr. Barriolas.
Thank you.
So 2 or more, can you explain that in a little bit more detail, what you mean by that?
Yeah, so the classic autoantibodies that we look for right now are directed against insulin. And that makes sense. You know, what do beta cells do in the pancreas? They make insulin. What's diabetes? It's not enough insulin. But then there's also other autoantigens. So the next one that we look at is glutamic acid decarboxylase 65, so antibodies against that. And then the next one that we look at is something called IA2, antibodies against that. And then the next one is something called zinc transporter 8 or ZNT8 and antibodies against that. And those are the 4 classic ones. And then there's another one called ICA or islet cell antigen. And that one isn't looking at a specific protein. It's actually looking at across slices of pancreas, does anything stick at all?
So we're looking for 2 of those autoantibodies.
Correct.
Screening. Dr. Barriolas, what were you going to add to that?
Yes. So he had mentioned that there was this consortium. So there's a group of professionals who are talking about the different tests that are available and the different antibodies they're looking for. But I want people to realize that regardless of where you're at in this world, going with the test that's available to you is going to be in your best interest, right? Because depending on the labs that are used, if you're at a university hospital-based system, they may have more difficulty accessing certain labs, certain tests. So just thinking about having a test that's available to you, regardless of what the experts are saying is the best, if you have access to one, to go with that.
That's an excellent point. And following up on that, let's say that a person is listening to today's program and they are inspired to get the screening done for themselves, for a family member, for someone out in the community. How do you begin that discussion with your physician, healthcare provider, Dr. Barriolas, to start the process? Like, some people may feel like they're alone on an island to get this process started. Where do you start to do that?
Right. So being your own advocate, many of us living with chronic conditions learn that you have to use your power of your words. Talk about what you're feeling, what you're concerned about, why you want to get tested, what you've heard about, pros and cons, and really have that conversation. I highly recommend individuals, when they have an appointment with their primary care team, their pediatrician, whatever the case may be, that they come in with a list and prepared, right? Because we often don't have as much time with our healthcare professional and our healthcare team that we would like. So if you come to that meeting prepared, like you would run a business meeting, have your agenda, have those bullet points listed here, and have that included as one of your points, and make sure that issue is addressed before that provider walks out that door.
Really the definition of person-centered care, right?
Yes.
Having extremely prepared. Dr. Gaglia, going back to the core of the screening questions, who should be screened? And we're talking about people with diabetes, with type 1 diabetes, who may go to a family member and try to get them screened. But can you talk about who right now we're recommending screening to? And are we looking at screening for the community at large? Should everybody be screened? What is the criteria?
Well, the last part of your question is actually difficult, but the way that we think about things in medicine is we think about pre-test probability and post-test probability. And the reason we think about it that way is because no test is absolutely perfect. And so if you go in a population where something is very rare, you're going to get a lot of false positives. And so generally what we like to do is you start in populations that are already enriched, because then you're less likely to get false positives. And the same thing is true with these autoantibody screening. So I'm a diabetes researcher, and the people that we screen the most often when we're doing diabetes research are actually family members. Because if you have a first-degree relative of type 1 diabetes with type 1 diabetes, you have 15 times the general population risk, because it's already just enriched there, because type 1 diabetes has genetic underpinnings. And by having a family history, you know the genes are somewhere in the family. And so that's the lowest hanging fruit, so to speak, is if you have a family history. And within TrialNet, which is one of the research consortiums that I participate in, we offer screening to family members of persons with type 1 diabetes who are first, second, or third degree relatives. And this screening is actually offered at no cost. And one of the other reasons I like this, having it done through a research study, is it's not in your medical record. So if you have concerns about this being in your medical record and your insurance company having access to it, then to me, it makes more sense to do it through a clinical trial. And there's other clinical trials that can have broader availability, such as the ASK study, where you actually don't need to have a family history. And so you just need to see what studies are potentially available in your area if you want to go the research route. Or again, you could go to your pediatrician or your family doctor and have a discussion with them. And again, generally, I am recommending this for people who have family members. Also, in some parts of the world, there's genetic testing that's available. So there's genetic risk scores that have been developed. And if you've had genetic testing, it indicates you're at higher risk. Even if you don't have a family history, it might make sense to get tested. And then type 1 diabetes as an autoimmune disease does run concurrent with some other autoimmune diseases. And so it might make sense, if there's a lot of autoimmune diseases in your family, the genes potentially might be there for that reason as well. Screening might make sense too. So from a population standpoint, the prevalence of the disease goes down. So one, you need to make sure if you are doing population-based screening, you have very good assays to try and decrease these false positives. And then two, it's also very important that you have adequate methods of following up on these individuals, because you potentially identify a lot more individuals. And the world is moving towards population-based screening. In Italy, for example, it was recently made via law that they will pay for population-based screening, and they're putting those together. There's been some research studies in Germany where they're doing in certain regions of the country population-based screening. But I think the important thing for that is if you are going to do population-based screening, you have good assays for that and the appropriate resources for follow-up, because you will identify a lot of people. If you actually talk to a person who's been diagnosed with type 1 diabetes, more than 80–90% of them will say they have no known family history. And that's true, because the majority of people who are diagnosed don't have a family history, because the genes are very common.
Yes, and there's a lot to consider with that. And when you say a family member, do you mean a direct family member, like a parent, a child, a sibling?
So a parent, child, or sibling would be what's considered a first-degree relative, but a half sibling would put us out at a second-degree relative. A cousin would put us out at a third-degree relative. Those all count. So if 1 through 3, it does make sense to do screening.
Excellent. As a reminder to our attendees who are participating today, if you have any questions for our experts, please type your questions in the chat so that we can ask them live today. And Dr. Barriolis, I had another question as we're listening to all this in-depth, excellent information, but there is a lot of information. What does a person do who is, again, who's living with diabetes and is very overwhelmed about one of their children already have it, and they're going for the screening for their child or several of other children? How do you speak to them about all of these advancements? How do you actually have that conversation? How do you lessen the anxiety about having potentially two children who have type 1 diabetes, which is not another child with diabetes, it's an exponential adding on to that. How do you address those concerns when somebody is considering screening or you want to recommend screening as a healthcare professional?
Before I answer that question, I'd like to follow up a little bit about what he mentioned, because he mentioned about research trials for people to get screened. So I just want people to be aware of clinicaltrials.gov that they can access to see if there's clinical trials going on in their area with regards to type 1. You enter in your zip code and the list of those trials will come out. Number two is testing for antibodies is not a one and done. So we have to remember that it may be negative the first go around, but that doesn't mean that you're out of the woods, and that repeat testing is done later on, whether that be a year, 2 years, whatever you and your healthcare team thinks about. So I just want folks out there to realize that it's not a one and done test if you do happen to get a negative.
That's a
So
great point, and
yeah.
I'll follow up a
Yeah.
little bit more on that afterwards, because no, it's a really
Yeah.
good point.
Yeah.
How much testing is too much testing? So we'll get a little bit into that discussion.
Sure.
So, and then the follow-up to my other question.
Yes, sorry.
No,
So
all good.
back to kind of, again, the emotional well-being of the parents. So there's a lot of resources now, thanks to our online technology. We're talking to other parents living with, having their children living with type 1, either through Zoom like this, conferences that are available nationwide, even worldwide, for families living with type 1. That camaraderie that can come with that. Even if you don't actively engage in the calls or the conferences, just sitting back and listening, because what'll happen is you'll realize I'm not the only one who has these feelings. I'm not the only one losing sleep. I'm not the only one that potentially has now started a medication for anxiety or depression because it's just gone through the roof by adding that additional child potentially with type 1. So it can help normalize some of those feelings that you're having because all the emotions that you're having are completely normal and validated, but it can be further validated by others having that those same feelings. So just talking to other families, getting to know them, reaching out to the local chapter of Breakthrough Type 1, the JDRF, they have conferences available as well regionally where you can have this in person at a very low cost or free.
What a great suggestion. And that peer support is everything, coming from a parent's perspective, a sibling's perspective, and there are so many peer-related resources that are out there. Thank you so much for that. That's a really great suggestion. Community is everything in this, isn't it? Very, very important. Dr. Gaglio, let's go back to the question of, because we just kind of got on the topic, how much screening is necessary? When is it too much screening? If someone tests positive for one autoantibody, when do they go back for the next screening? How does that all play out?
Yeah. So we've been, over the last couple of decades, accumulating a lot of data on the natural history of this disease. And so first, it's unusual to develop type 1 diabetes before age 1. So if someone does develop it before, then we look for other things that might be going on. So it doesn't really make sense to screen that young. We don't have to do it. If we start looking at the autoantibodies, though, screening from birth in people who are genetically high risk, there's a peak at about age 2, actually. And so generally, I recommend start screening around age 2, believe it or not, because that coincides with that peak. And that's what makes sense to me, to start when you would expect to see a larger percentage of the population becoming positive and those who are genetically at risk. But it doesn't capture everybody. And as you heard, you could be negative then and become positive later. So then when do you check? How often do you check? And so this process takes time. And so right now within TrialNet, we're offering repeat screening once every 2 years. And so I think that's a reasonable time frame for most families. Some of this is somewhat family dependent, though, in that families where the diabetes presents younger, the disease tends to be faster. So you might want to screen those earlier and more frequently. And families where the disease presents later, in your 20s or 30s, that disease tends to be slower. And so maybe you can space it out a little bit more in the screening. But, just as a general starting point, once every 2 years makes sense. And then the majority of people, at least in the pediatric population among kids who are going to convert by around 11 or 12 when we're starting to go into puberty. And so it makes sense to, be more screening then, and then maybe you can lighten it up a little bit after that. And within TrialNet, we offer screening for repeated screening through age 17. And I think that that's reasonable as well. But it is true, people could still change after that point.
What about the cost of the screening? What is
Yeah.
the cost to be screened?
So it depends on how you do it. And there's a great deal of variability in the cost of these assays. And it also varies in how you do your assays. And so the different screening strategies are, one is you get the 4 recombinant protein ones, or you can get all 5, including the ICA. And that's going to be relatively expensive. If you do it through your healthcare provider and you're paying cash, that could be over $1,000 if you did it that way. If you do it through a clinical trial, often those are actually free within the confines of the clinical trials. But often within the clinical trials, as a cost-saving measure, the way that they'll do it is staged, and that they'll check the autoantibodies that are most likely to be positive first. And then if one of those is positive, then they'll screen the other ones. And because, again, we're looking for 2 autoantibodies. So they'll start with insulin and GAD, because of the autoantibodies, those are most likely to be positive. And then if one of those are positive, then they'll get the IA2, the zinc transporter 8, and potentially the ICA. It's just a little bit more of a cost-effective strategy, but all of those strategies are perfectly reasonable.
Okay, thank you. Dr. Barriolis, anything to add to that? Okay, no, okay.
Sorry, nothing,
No.
sorry.
That's okay. Well, you didn't know. Okay, that's thank you so much for that. So in Dr. Gegley, if we go back to the staging and some of the questions around that, and as we started at our discussion around DKA, if somebody is diagnosed in DKA, they weren't screened, they were hit hard with type 1 diabetes, what's the medical issue around that? Why is that a problem? Why are we reaching out to make sure that people are screened? What is the issue with being diagnosed in DKA?
So there's really 2 issues actually with being diagnosed in DKA. The one is the acute issue, and that DKA is life-threatening. People die in DKA, and obviously we don't want that for anybody. And so it's important we recognize them before they've made it to that point where they have DKA, so we can get them and start treating them before they're in a life-threatening situation. You don't want to have someone in that emergency situation. It's better to never be there. The other one is actually a little bit more curious, which is it turns out people who are diagnosed in DKA, their disease course tends to be not as good as people who are diagnosed not in DKA, in that they tend to need more insulin sooner, faster. Their blood sugars tend to be more variable. And so some of this can be what we call ascertainment bias, and that maybe it's just because we caught somebody earlier, and so we have a longer runway that we're seeing. And some of it could be that by the fact that the person was in DKA, the beta cells really don't like those high blood sugars like that. And they might have killed off more beta cells just from having that occur. And so either of those are potentially possible, but both of those lead to the point of, wouldn't it be better if we could catch people earlier? And then we can try and avoid that and hopefully make their beta cells happier and make their beta cells last as long as possible. And that isn't even getting into the point that if they have a lot more beta cells when we catch them, and if we do have a therapy, we have more material that we're starting with in the first place. So we're not at a place where we can grow beta cells back in people, but we are at a place that we're starting to get drugs that decrease the killing by the immune system of those beta cells. So the more beta cells you have when we do give you a treatment like that, the better positioned you are for responding to that treatment.
And what does this mean in terms of delaying the onset of stage 3 if this is identified through screening and we do impart one of these treatments?
Right. So right now we have one approved therapy. The first approved therapy, which I mentioned, is a drug called teplizumab, and that's been approved currently for people who are in stage 2 type 1 diabetes. So these are the people who they have the autoimmunity, they're having some destruction of their beta cells to the point that their blood sugars are abnormal. And then the goal is you give these people the teplizumab, and that's going to slow that destructive process. And it actually, in the clinical trial, delayed onset of stage 3 by about 2 to 3 years. So 2 to 3 years is only 2 to 3 years, but that's a start. And that's where we are right now. And we're hoping that we can extend that and make that last longer.
And Dr. Barriolas, how would that 2 or 3 years impact a family educationally, anxiety-wise, who now has this 2 to 3 years before they may reach stage 3? How would that impact them? How would that help them, if it would help them?
So probably the first thing that these individuals would learn about are those symptoms of DKA, because DKA is not something that just happens overnight. It develops through time. For some, it could be a couple days, for others longer. So there's a lot of toll that it takes on the body to be in that state. So you had asked earlier about why you're trying to prevent it, because then those individuals often have to be hospitalized. So they're missing school, they're missing work, potentially there's a financial concern with being hospitalized. So these are all things that we're trying to avoid. Why is that 2 to 3 years important? Again, it goes back to that time and knowledge is power idea, because they can learn about how food affects blood sugar, how stress, sleep, alcohol, medication, what the medication options are. We don't just have one kind of insulin at this point. There's many to choose from. There's many ways we can deliver insulin at this stage, and that's continuing to get bigger and bigger. How we monitor our blood sugar. It's not the we're not boiling needles and, peeing on sticks like we were 30, 40, 50, 60 years ago. So all these individuals can see what works best for their family. Look at, if it's a child, where's that child at developmentally? How can we get he or she involved? Because I'm always an advocate for getting that child involved in managing their condition as much as appropriate for the stage of that child. So starting this early, practice makes perfect, right? Learning how to carb count, learning how insulin affects the body, what signs of low blood sugar and high blood sugar is, how these kids are going to talk to family members about diabetes, or friends or teachers or bosses or potential partners. I mean, there's so much practice that can go on during those couple of years, because traditionally it happens overnight. When you get that admission to the ER for diabetic ketoacidosis, you may be given, a day or two to kind of ask some of these questions, and then you're sent home. And that's a lot to handle.
Yes.
Now you're able to spread that out over a few years potentially.
Yes, and it makes a tremendous amount of sense. And this is also why the American Diabetes Association and so many other organizations are bringing forward the importance of understanding the warning signs of type 1 diabetes, because that this is so important, because it's like being hit so hard when you are diagnosed in DKA. It's so sudden so much of the time. Thank you for that. Dr. Gaglia, going back to something you said a little bit earlier about other autoimmune diseases and how that may play into this, can you please expand a little bit about that and talk about what some of those other autoimmune diseases are to be on the lookout for people who may need to be screened for type 1 diabetes?
Sure. So it isn't yet clear which other autoimmune diseases, if you have that, you should be screened for type 1 diabetes. But a number of autoimmune diseases tend to go together. And with type 1 diabetes, these other autoimmune diseases include celiac disease, autoimmune thyroid disease, and autoimmune adrenal disease. And so they can go together in families. And if you have a history of multiple autoimmune diseases in the family, it may make sense that you might have higher genetic risk, and type 1 diabetes could be one of the ones in that bucket.
Do either of you have any positive stories of a family or a person who went for screening and they were autoantibody positive, and they did have 2 positive autoantibodies, but where the process really helped them in terms of being prepared or lessening their anxiety about what might come in the future?
Yeah,
So,
I'm happy.
yeah.
I'm happy to give an anecdote along those
Sure.
lines. One of the things I see, which it's surprising to some people, is so it's not unusual that we'll get families that a child is diagnosed with type 1 diabetes, and the family comes in to get the sibling screened. And I talk to the family and I say, we should screen the parents too, because the genes came from someplace. And on several occasions now, we've identified that a parent is actually at risk. And we've identified it in the pre-symptomatic stage, and it gives that parent time to prepare. Because otherwise, the parents are very surprised when they're diagnosed after their kid had been diagnosed. They're always thinking about the rest of their family, and they're not thinking about themselves. And when we identify them on screening, it really kind of changes that so that they actually do think about themselves, and it gives them time to prepare themselves.
That is thank you so much for sharing that. And I bet that that will help a lot of people to hear that. And they may not have otherwise known, not putting themselves first. Absolutely. Dr. Barriolas?
So in my situation, it was a sibling of one of their children who already had type 1. So the family, they knew the child wasn't doing well. They were picking up on symptoms. It was all too familiar to them. The guilt, again, back at the parent was, oh no, here we go again. I can't believe I have another one. But usually that sibling has been involved with their brother or sister with type 1 all along, or hopefully they have. So they already have a pretty good understanding of what's going on. But it's about incorporating the entire healthcare team to get that newly diagnosed child on board with recognizing how it's going to affect their personal life, how it's going to affect social life, academics, food choices, and just empowering them that they didn't do anything wrong to do this, to get this condition or any of these autoimmune conditions. It's just the flip of a coin pretty much. So you've got to very much iterate that constantly with these families, because guilt and anxiety are so laden. And it's important to talk to that child alone. If you've got some 6, 7-year-old, they still have, although they're young, they have a lot of feelings still going on. And often the parents talk over their child. So I always encourage parents to let that child sit individually with either their diabetes care and education specialist, their counselor at school, their behavioral health specialist in the community, their pediatrician, whatever the case may be, so that the child's words and feelings can be heard directly from the source.
And that's such fantastic points. And thank you for that anecdote, both of you, for those anecdotes. And Dr. Barriolas, I think you brought up a very important point, mostly about parents, but also you see it in siblings as well, about the guilt aspect of it, and just feeling very bad that you may have imparted this onto your child. So listening to the child and the child's feelings is extremely, extremely important. And I'm sure that you see that a lot in your practice as well. And Dr. Gaglia, moving on again with the screening process and the staging process, of the people who are, again, have the 2 positive auto antibodies, do we see any particular, and you talked a little bit about the age range, as people are getting older, if they haven't been screened for a number of years, at what point do you think that they should be screened again? If they had 1 antibody and they were like, oh, good, I don't need to be screened again because I only had 1, at what point should they go back and get screened?
Right. So within TrialNet, if somebody has 1 autoantibody, we actually then do annual screening to see if they're going to convert to develop more autoantibodies. And the majority of people who do actually do it within the first 3 or so years. And so if you stay with just 1 antibody for a very long period of time, it's unusual that you'll develop the other ones. Now, there is a little bit of a caveat or an exception to that. So first, if you have only one autoantibody, your risk of developing diabetes is not zero. It's about 20%.
Great point.
So again, our systems are not perfect. But even within that, there is some difference between the different autoantibodies. And if that autoantibody happens to be that IA2 one, that then goes up to 40%. And so even though that's only one autoantibody, those people have similar risk to people who have two autoantibodies in the short term. And so this is one of the reasons why it's important that when you get antibody testing, you do it through a place that can help you interpret the results, because there's a lot of nuances to this. And again, that's what I was trying to get at with in population screening. It's important that they have the resources to follow up on these things, because you need people who understand the results and can explain the results to you, and then also help take you to the next step, because after the autoantibody testing, we're not done. The next step after that is testing for the abnormal blood sugars and needing to understand how the right way to do that is and how to interpret those results as well.
So that's a great point. So if somebody went to be screened randomly, paying out of pocket at a commercial lab, they're not going to get the same follow-up support, potential treatment as you would if you went through TrialNet that's following you.
That is correct. However, if you went to that commercial lab and you were found to be autoantibody positive, even if you don't have a family history, you could then go to TrialNet, and TrialNet would be happy to repeat your testing. And if they identify that in their labs it's positive, enroll you within TrialNet, offer the screening for the blood sugars and see where you're at, and potentially offer participation in a clinical trial to try and decrease your risk of progressing to stage 3.
Oh,
So that is another mechanism of actually getting into TrialNet, is if you're known autoantibody positive from outside testing. Because again, TrialNet is interested in identifying people who are at very high risk of developing stage 3, because they do clinical trials to try and delay and prevent that. Teplizumab, as we had mentioned, was actually developed within TrialNet. And it was done because people were screened, identified had stage 2, and the clinical trial was done on those individuals. And that's how we realized this drug works.
Can you talk a little bit more about how the drug works and what the series of the drug is? Like, I think that people will be curious of how this all works.
Sure. So teplizumab itself is an antibody-based drug. And so it itself is an antibody. And it was originally developed in a mouse, but then they did what's called humanizing it. So they basically took away most of the mouse parts and replaced it with human parts. And what it targets is something on T cells called CD3, which is part of the T cell receptor. And so T cells have receptors. They're kind of like the eyes of the T cell, which is what it uses to see things in the body. And if it sees the right thing, it knows that's what it's supposed to react to. And so this is an antibody that binds to that, and it kind of blocks it, and it can also stimulate it a little bit. And so they genetically modified this so that it doesn't stimulate, or it significantly decreases the amount that it stimulates. And it's given as a series of infusions, and there are a series of daily infusions for 14 days in a row for the approved therapy. So, it takes 2 weeks of going ahead and getting this. And because when you give this drug, the T cells go down from the circulation, it can affect your ability to fight infections for a brief period of time, because those T cells go out of circulation. And then after about 6 to 7 weeks, that you rebound and you come back up from that. But then the effect on preventing diabetes is durable for about 2 to 3 years. And basically, it has taken a population of your cells. They're called CD8 positive, KLRG1 positive, TIGIT positive cells. You don't need to know all those details, but basically what it has done is it took cells that were previously activated and basically made those activated cells, the cells that were attacking your pancreas, they were activated, they're attacking your pancreas, and makes it so that they don't see things anymore for a while. It kind of puts them to sleep for all intents and purposes. So it took the cells that were doing destructive things and puts them to sleep.
What a fascinating process. And Dr. Barriolas, that is, as Dr. Gaglia pointed out, it's a commitment to go through that process for that 14 days and some of the other possible side effects of taking the medication. How do people cope with that, with the 14 days and the commitment and the family, and how do you do that? Of course, there's a lot of positives on the other end as we were talking about it, but what about the coping mechanisms around taking the medication?
Some families will choose to go that route and some won't. Like he said, it delays the flipping of the switch by about 2 to 3 years. This medication that we have does not stop the process permanently. But what the research has done is this is the first step, with the hopes eventually that we will be able to turn off that mechanism where that autoimmune response occurs in the body. But you mentioned this, coping with this, routine of 2 weeks daily, needles. Again, if it's a child, a teenager who is very advert to needles, does not want to be poked and prodded, it's important to talk to that child. Again, developmentally appropriate, age appropriate, about do they want to do this? Because it's not a cure. And it's very important that people realize that it's not a cure. There are side effects. You are more prone to other viruses and things like that because the T cells are decreased. And see how it would work in their schedule with school. How much school would they have to miss, or work would they have to miss? Is it feasible for the family? So just having that open dialogue with individuals in your healthcare team to make sure everybody's on the same page.
Yes, there's a lot of things to consider, and there's also a lot of hope on the horizon and in the future with that medication and so much other things that are on the horizon. How do people, Dr. Gaglia, how do people learn more about this therapy? We're talking about the screening and the staging and avoiding DKA and all the not so good things that go along with that, and the hospitalization and the cost and the economic burden of a lot of this, not only the direct burden of diabetes, but as Dr. Barriolas was mentioning, the loss of work, the loss of school, taking care of people. But how do people manage with the cost of the medication? And is that also approved through insurance?
Yeah, so for people that meet the indication for the drug, we're finding a lot of the insurers are paying for it. I mean, you need to prove that you meet the qualification for it, but we haven't actually had too much reimbursement issues for it. And I'll be honest, likely because it's such a niche population,
Yes.
because you need to get screened, you need to be in stage 2. And so because those numbers are relatively small, the insurers are like, well, this drug works. We've got data that it works. We're not having to treat a lot of people. We'll go ahead and we'll pay for it. If you had to pay out of pocket for it, the drug itself costs close to $200,000 list price. So it's an extremely expensive drug. I don't know what the insurance companies have negotiated as far as their prices are concerned, but again, it's been our experience that if you meet the criteria that is in the label for the drug, normally we can get it covered and for people. I did want to clarify one point, which is, we've been saying it delays it by 2 to 3 years. I just want to make sure people understand that that's on average, and that there's some people it doesn't really work very well in. And we've had other people where it's been more than 10 years without the development of diabetes. So the 2 to 3 years, that's average, but there's some people who do better and some people who do worse. And, it's just individual variability.
And I know we covered this at the very top, but in case somebody joined a little bit later, what is the method when somebody's going to be screened? How is that blood drawn? And are there different methods for, I know you talked about it a little bit at the top, but I think it's a really important point because some people are a little bit squeamish about having that done as well.
Yeah, so classically, there's 2 ways to do screening right now. The way that I actually prefer is via phlebotomy, so a venipuncture and blood from a vein. And the reason I prefer that is we can get a large quantity sample. We don't need a very large quantity. And within TrialNet, we do all of our testing on 2 mLs of blood. So, I mean, it's still a relatively small amount. But for people who don't want to do venipuncture, we can do it via finger stick as well. And the volume that's required for the finger stick really depends on the specific assay, because there are some assays that can get by with super small quantities of blood, and there's others that we need to fill a capillary tube for it. But both of those can be done from finger sticks. And for ones that can be done from finger sticks, to me, the real advantage of that is you can have a kit sent to you, and so you can do it from the privacy of your own home. And so if you don't live near a physician or near a lab, you can do it that way. But if you do live near a lab, we can have it drawn there. Or if you're going to the pediatrician already and they're due for other blood at that time, we suggest just doing it at the same time, because then it's not an additional step.
But that's a really good point, because you can get the home kit and do it on your own time in your
Correct.
own space. Dr. Barrielos, do you have anything to add to that?
No, again, this goes back to having options is great, because options leads to advancements. That means doors are opening. We didn't have these tests a few years ago. These antibodies, you mentioned 5, were just identified, what, in the past 10, 15 years, I think, if that. So even people with longstanding type 1, they don't know what antibodies that they have. And some are interested in getting this testing just to see, out of curiosity, what antibodies they do carry. But researchers and healthcare professionals are trying to minimize barriers as much as possible. They're talking to government officials. They're getting it into regulations. They are getting insurance approval, Medicare, Medicaid, TRICARE, the whole kit and caboodle, commercial plans. So you have a big team that's behind this and trying to make this accessible for as many people who need it. Our ultimate goal, like they're doing in Italy, in I think Germany, that was mentioned, is to have this population based. So we need people to participate. We need to gather the data so that we can get this published, validated, so that we can get more kind of hands in the pot and say, wow, this really makes a difference. This is worth the cost of the test. This is worth the cost of the medication that's FDA approved now. Because numbers, we need the numbers to make it more accessible to more individuals.
Yes, absolutely. And I think that this discussion today, and as we're going forward with this discussion, we're hopefully making this seem more realistic for a lot of people who are listening today, of how the screening can be done and all the benefits that are associated with the screening, and the discussions around it, reducing anxiety and stress. Knowing and knowledge is power, Dr. Barrielos, as you said earlier. It is. And even though it's very scary, and living with type 1 diabetes for most people is so scary and so difficult, and a daily battle, so you may not want to recognize that information, but how helpful everything that we've been discussing today can be moving forward, and knowing what might lie ahead, and having the ability to potentially delay the onset of stage 3 and the clinical diagnosis of type 1 diabetes. Can we go to the next slide, please? So as that's coming up, I think we're going to come to the next slide. Here we are. Some of the things that we've talked about today, and we're kind of bringing it together at this point, is to screen if you have a family history of type 1 diabetes, as well as those with a family history of other autoimmune disorders. And Dr. Gaglia did a really fantastic job explaining what those other autoimmune disorders might be. And if you have any questions about this, please contact your healthcare provider. Know your risk of developing type 1 diabetes. This can help empower you to become educated about the disease process. Knowing the warning symptoms and signs of type 1 diabetes. It can be not only misdiagnosed, and it is misdiagnosed in so many people, and underdiagnosed. We need a diagnostic differential in so many pediatrician offices, especially. Know the warning symptoms. Discuss with your doctor or your healthcare provider for more individualized care plans. And at this point, I would love to, and please take your time in explaining this, Dr. Gaglia, any takeaways or anything that I didn't cover in questions today, or that our attendees didn't ask in questions today, that you'd like to bring to light at going towards the top of the hour.
Yeah, I actually just want to echo one thing that Nicole said, which really it's knowledge is power. And I think it's extremely helpful to know where you stand, and that's all that this screening is. It's just giving you information. And then you can decide what you want to do with this information. Does this mean you want to participate in a clinical trial? Does this mean you want to get an approved drug? Does this mean you want to be more aware of symptoms you should be looking out for? It's just giving you the information and so that you can decide what you want to do with it.
That's excellent. Thank you so much for that advice. And Dr. Barriolas.
Yes. So some people may be thinking, I don't want to know this information. It's scary. Diabetes stinks. There's too much involved. But diabetes shouldn't really limit you. It doesn't limit you. It shouldn't limit you. I have those conversations with folks all the time, explaining that you can be a professional athlete. You can travel all over the world. You can go deep sea diving, mountain climbing, have children, drink alcohol, all of those safely, and still have diabetes. I mean, to be honest, at this point, you can be a pilot and still and be living with type 1 diabetes. So don't let this condition halt you in your feet. Don't let it guide your decision. It's always going to be in the background. It's always going to be a piece of your puzzle, but it doesn't have to stop you. By having this information, by knowing that you have these antibodies early on, gives you that time, like I mentioned earlier, to learn about food, medications, technology, resources, support systems, but also to develop your healthcare team. We know diabetes affects you head to toe, literally brain to toe, skin, heart, obstetrics, gynecology, vascular, every body system is affected by diabetes. So you can find those team members that work for you. We have to include behavioral health too.
Yes.
There's this term called integrated behavioral care, integrated behavioral health, integrated primary care, depending on where you look, where people like myself, psychologists, social workers, licensed professional counselors are in the primary care clinics, are in family medicine, are in pediatrics, are in OB-GYN to help you with life change, life transitions, stress management. Although I'm a diabetes psychologist, often what I talk to people about is sleep, of all things, time management, of all things. Normalizing that interaction with behavioral health professional from day one, even before day one, before that test, before that blood draw or that finger stick is done to check. Normalizing that. It doesn't mean you're sick. Doesn't mean you've got something wrong with you. We all have challenges. Sometimes you can see them and sometimes you can't, right? So talking to people who are not family, who are not friends, an outsider is what can be so beneficial because you can be free. You can be open. You can be honest without, embarrassment or feel like you're going to be judged. And the same thing with that child, the child who may have a new antibody test, they don't know what to do with these emotions. So they may be acting out in other ways. They may be fighting more. They may be arguing more. There may be a decline in grades. Who knows? Where the issue is really the dealing with the emotions of this condition that they're going to likely have for life. So by having that behavioral health professional out there gives them that outlet in a healthy way, right? And some of you may be asking, well, how do we find people, behavioral health specialists who, work and are knowledgeable about diabetes? So often, if you are near a university hospital system, there is a team integrated already. So I say make friends with your hospital social worker. They usually have great resources in the community. If you don't live in that type of environment, potentially you're more rural or something, there's a ADA, American Diabetes Association, has this list of behavioral health professionals around the country that have kind of received the stamp of approval that they have additional training with diabetes. So you can search by zip code to see if you have folks like that in your area. So that's another resource. Social media platforms, if that's not, if you're not able to find somebody through ADA's website, putting the word out through social media. Hey, do you know someone I could work with? Because you have community health workers, which we didn't really talk about much today, as an additional source of support. You have health coaches, which is an additional source of support. So there's so many people out there who can help you through this transition. Even your pharmacist, your dietitian, your nurses, your physical therapists, your speech language pathologists, they're all going to be help you on your journey through the having those conversations with deciding whether or not to be screened, at what interval, and then what happens if some of those come back positive.
Well, thank you so much for that. It's so important, as is mental health professionals as well. So thank you so much for that. Next slide, please. And your feedback is so very important to us. Please know that you'll be receiving a very short survey emailed to you following this event, and we really appreciate your feedback. Next slide. There are more Ask the Expert events coming up on August 13th at 2 p.m. How to recognize and treat disease burnout on September 10th at 2 p.m. Atherosclerosis, head, heart, and feet relationship. Please register at diabetes.org/experts. And on behalf of myself, Dr. Nicole Berriolis, and Dr. Jason Gaglia, thank you so much for coming to our event today. This has been amazing. You were both amazing expert guests. I think that everybody learned so much. We also want to thank Sanofi for supporting this event. And please email any questions that you may have that you didn't have a chance to ask today at askada@diabetes.org. And please remember to include Ask the Experts Q&A in your subject line. We appreciate your time. Thank you so much, and we look forward to seeing you next time. Thank you.